Well, welcome to Tuesday morning, and Tuesday mornings is when we set aside some time for our friends over at GRMC for this portion of the program. Your healthcare partners is brought to you by GRMC, where patients are partners, and if you'll take a look at your TV screen, then you can be treated to the same two guys that I'm looking at right now. Dr. Arthur Ko is with me. He is a radiation oncology physician, and radiation oncology technologist is Jeffrey Corwin. Hi, good morning.
Good morning.
Welcome. How are you guys?
Great, thank you.
You've been on Guam for a while, have you? Yeah, I think you guys look like you've...
Just about 2 years for me.
Just about 2 years. That's long enough. I mean, 2 years in Guam years is like 10. Dr. Cohen, how long have you been in Guam?
About 2 years.
Okay. Where did you come from?
I came from Indiana.
Okay.
I used to work at Indiana University Medical School before I came here.
I see. You guys aren't a traveling team, are you?
No.
Okay.
I came from actually...
Like Dr. Cohen is sidekick, the guy who runs the machine. Yeah.
I actually came from Chicago.
Oh, okay. Mm-hmm. Well, then you're probably loving the season right now.
Yes.
Yeah. Or you
no.
miss...
Actually, I'm not ready for seasons again yet.
Yeah.
I'm loving the perpetual summer thing.
Yeah, we like it too. Thanks a lot, Kev, for the hookup. Well, I'm glad to have you in the studio today, and especially this month, being Breast Cancer Awareness Month. And, you know, there's any number of organizations out there that are trying to motivate women to go and get their mammogram. And it is because of that one procedure that allows so many of us to feel confident that we have been looked over and picked at and prodded, and to come out with good results. And sometimes that isn't always the case. And enter your profession and your specialty, Dr. Ko, a radiation oncologist. You've got to explain that to me a little bit more. Is this one of the three sort of specialties in dealing with cancer?
Yes, that is correct.
Oh, well, ding, ding, ding. All right. The other would be what? Medical?
The other
surgical?
would be surgical oncology.
Okay.
And the last remaining one is medical oncology.
Okay, medical oncology. And so radiation oncology is basically...
We use radiation for cancer treatment. Mm-hmm. That's my job is.
That's your job. You know, and Guam has been lacking. There has been a void. Almost as long as I can remember, there had been a huge void. I'm sure that you recognize that when accepting the job to come here. There was no place for us to go. There was no place for cancer patients to go other than off island to get some kind of treatment. But now you have an entire department dedicated to this at the Guam Regional Medical City.
Yes.
Yeah.
We have one of the very up-to-date, very highly advanced radiation treatment machine available currently at GRMC, and it can be used for treating all kinds of cancer patients.
Yeah, and that's your job, isn't it, Jeffrey? You
That's exactly right.
You hold out great hope. He just told me that the linear accelerator machine is called Hope, affectionately known as Hope.
Yeah, when you walk into these situations, you're already dealing with so much, and you see this giant thing coming at you. It can be intimidating, it can be frightening, and you're already, feeling kind of low and wondering what's going to happen next. The least we can do is try to, ease the burden. And so one of our first patients said, I would feel a lot better if I could just give the machine a name.
Good.
There you have it. And so now we call her Hope.
And it's a female is what she is. So it takes a little bit of the edge off.
That's right.
In the treatment, are there some miscommunications or misconceptions about radiation therapy? I know that immediately people come up with a whole list of fears and concerns about the side effects of radiation. Is there anything out there that is a misconception about it? That's okay. You can just go ahead. Yeah.
I think the miscommunication coming from the fact that back in old days when we just began to start using radiation for cancer treatment, back then we didn't know what we are doing. So sometimes patient was severely overdosed per se, and they end up having a lot of consequences from overdose situation, or undertreated sometimes because we didn't know what kind of radiation needs to be given. And because of that, misconception came from the fact that patient was undertreated or overtreated, and that's
how many years
main
did it
reason.
take to strike that balance where you knew just the correct dosage?
I think maybe about 20 years ago that we started,
really getting
into the actual radiation biology part, and there were a lot of sciences was backing us, and then that's when we began to realize, okay, radiation is good. If you use it, and if you use it correctly, it can be a game changer.
Yeah, talk to me about the game changer. I have seen patients walk away from the therapy and from the treatment, and being completely in remission for the rest of their lives. So it's clearly very effective. But is it a last line of defense, radiation? Is there a misconception that if you have to have radiation, then it's a stubborn cancer?
Like, is it truly palliative, or is it definitive treatment?
Right.
Well, sometimes we use radiation for palliative purpose. Palliation meaning to relieve symptoms, either pain or some kind of impending cord compression per se.
Okay.
But in some situations, we give radiation more in definitive setting. When we use the word definitive setting, I have cure in my mind.
I see, and the patient knows of the difference.
Yes.
And that's like part of the communication.
That's clearly communicated from the get-go.
Okay. And so, which of these do you see most on Guam? We have a very high cancer rate on Guam.
Yes. In mainland setting, I would say definitive treatment versus palliation would be about 70 to 30% range. But in Guam, unfortunately, I would say about half of our population would get palliative radiation treatment instead of more definitive treatment.
But with ongoing outreach, hopefully, we can make that, make those numbers change in a more positive way.
I think the part of the reason that we are giving more palliative radiation treatment is because patients wait until the last minute. Because of the pain symptoms, instead of seeking care from the very, very early stage or from very beginning, they wait maybe because of the lack of insurance, maybe because of a fear for doctor in general. They wait until last minute. When they come with a significant pain symptoms, sometimes it is just too late to offer more definitive treatment.
Yeah.
Or sometimes there's just the difficulty of talking about cancer itself, talking about illness, the stigma of saying,
because people believe
sick.
it's a death sentence. I mean, I think that also, this is something historically that has scared people, that once you had cancer, that there was no cure. And so the battle is a hard-fought battle. So people, don't want to take on a hard-fought battle, and would perhaps, wait until they feel like they're ready. But because of this kind of treatment, have we made great, strides in the growth of the cancer rates? Although that you see that Guam, really does have a bigger problem. Have you seen, with the introduction of this equipment and of this service on Guam, have you made a dent in the numbers? That's okay, Doctor. You can go ahead and just.
I think in the mainland setting, the actually cancer mortality rate is going down overall. However, that's not the case in Guam.
Right.
Cancer death rate is actually going up higher and higher. I think we need to intervene more proactively in Guam, because maybe more patient education is needed.
Mm-hmm.
Maybe more outreach program is needed.
Get the conversation started sooner.
Maybe more, free cancer screening is needed to reach out and, educate people. Okay, you need to come to see us in early stage setting or even cancer screening setting, instead of wait until the last minute.
Yeah, and a lot of that is because people may not necessarily, and not that these campaigns are not effective, because there are a number of organizations that provide this service, Guam Cancer Care, for example, where you can go and get a screening. But I think what's interesting about Guam and people who live here is that cancer is in the family. Mm-hmm. So you have a lot of these telltale signs of it being quite obvious that it could happen to you. And like you said, people are just too afraid to take it. So maybe the education is there. It's just in motivating people, to actually want to take the next step. Mm-hmm. You must deal with these kinds of patients, Jeff. You have the one-on-one with them.
Yes,
working
exactly.
the
One of the great things about what I do is that I get to build a relationship with the patients, because we don't just see them once and then send them on their way. Mm-hmm. We actually see them for 2 weeks, 3 weeks, 4 weeks, 6 weeks at a time, and we continue. Dr. Ko continues to follow them for weeks to months at a time. So we build relationships with them and with their caregivers, with their support network, and we can help get these conversations started and keep them going. And we can help educate about what these family connections mean as far as risk of risk of cancer in future generations, that sort of thing. But also, it helps us to care for these people better and hopefully spread the word that there is help on island now.
With this this linear accelerator, it almost sounds like a sci-fi movie, really, like a time machine or something. But a linear accelerator, and having what you said was the state-of-the-art equipment, and what is the state-of-the-art equipment? What can it do that was deficient in other machines that you've used in the past?
Our machine actually has a lot of imaging capability. We have to see what needs to be treated before we turn the beam on. Mm-hmm. So if treatment machine has all this imaging modality available, built in, then we can actually give better radiation treatment. Mm-hmm. So our machine actually has diagnostic, sort of like X-ray.
Does it have I don't mean to be irreverent about it, but I don't know what the terminology is, but you have a better chance at zapping it, really, is what we're talking about.
Yes.
I know, probably not the wisest medical terminology I'm using, but bear with me. But it really is just that, is it not?
Well, if you consider the fact that in most areas of the body we're aiming at a target, a bullseye that's very near a lot of other healthy tissue and a lot of critical structures. What we have now with this new imaging is the capability to focus our radiation on the area that needs it most while sparing all that healthy tissue. And we can do that daily. Instead of just taking a picture once a week to say, okay, I'm looking at the bullseye and I'm pretty sure I'm missing all this other stuff. Now we can actually look daily and say that I'm within millimeters of my bullseye and I'm certain that I'm not hitting that other healthy stuff.
So if you're not hitting any of the other healthy stuff, or at least the chances of you hitting it are fewer, then what are the side effects if you're just hitting what you need to hit?
Depending on the area of the body that we're treating, virtually none. We can actually shape the radiation field such that we minimize the side effects, and therefore the patient can tolerate the treatment a lot better than they used to.
No kidding. Is there any pain whatsoever during the treatment?
Just putting up with Dr. Ko.
But other than that, then what about how people used to lose their hair or that sort of thing? Are those not side effects that are prevalent so much anymore?
The only time the patient can lose their hair is when we give a whole brain radiation treatment. When lung cancer or breast cancer, it can readily metastasize to the brain. And if they have multiple lesions on MRI, then we have no choice but to give whole brain radiation treatment. After whole brain radiation treatment, they could lose hair, but I expect their hair will be growing back.
Actually, I've seen hair grow back even better than when they had it. I have a friend who went through treatment, and she was completely bald. And then her hair grew back, and it was like she looked like a movie star. So, it was better hair than before. What do we get? Like new, fresh hair follicles
Sometimes
or something?
their hair color changes after
really?
regrowth of hair. Yeah.
But you don't get physically ill though. Other than that, there's no nausea or any of that other kind of stuff.
They could feel fatigue. They could feel tired from the radiation, but those are easily dealt with.
Yeah.
And the way that I like to present that with the patients is, if you think about the radiation is doing damage to the bad cells, but it's also doing, there's some healthy cells wrapped up in the area that we're treating as well. That fatigue is simply your body working harder to repair the healthy cells. So if you think about it in a good way, just trying to put a positive spin on it, the power of a positive attitude, that kind of thing.
Yeah, hope.
Exactly.
Hope for sure.
Choose hope every time.
What about the difference in the specialties between medical and surgical and radiation? I don't mean to pit any one specialty against the other, but how much more effective is radiation, or can it even be compared that way?
I don't think you could compare what one specialty is better than the other, just because sometimes you need all these three specialists to work together. For example, for rectal cancer, before the operation, we need to give what we call surgery or neoadjuvant chemo and radiation together to shrink the tumor or make a surgery better or easier.
Yeah.
Then after we are done with the chemotherapy and radiation together, then surgeons come in. So it's a combined effort.
I see. Okay, and that would be one instance where all three of the specialties can work together. But singularly, this is the way to go.
Singularly, depending on what name, give me the name of the cancer, because each cancer needs to be treated differently.
Lung cancer.
If it is stage 1, then we can either offer surgery or radiation. The outcome is probably equal, or maybe radiation is slightly better in that sense.
Okay. Give me a cancer where radiation works every single time.
Every single time?
Well, for the majority of the time, in your humble opinion.
There are some radio-resistant tumors. Radio-sensitive tumors, like a GIST tumor of the stomach, which is highly sensitive to radiation.
Okay.
And for that treatment, we give only a 3-week course of daily treatment, and usually it's
and you're
cured.
pretty done. Wow.
Yes.
Well, it's a far more hopeful outlook now that I've spoken with you.